Hey all, welcome back to the Real Life Pharmacology podcast. I'm your host, pharmacist Eric Christensen. Thank you for listening today. Go check out reallifepharmacology.com. We've got that free 31-page PDF on the top 200 drugs. Great no-brainer to have simply for an email there. So absolutely free, no cost to you. Just an email is all it's going to cost you. With that said, we get you out new updates when we've got new podcasts and other content available as well if you're on our email list. So definitely go and get that done at reallifepharmacology.com. The drug of the day today is Naltrexone. Brand name of this medication is Revia, otherwise known as Vivitrol as well, which is an injectable formulation of this medication. So naltrexone is an opioid antagonist. If you've listened to the podcast for some time, I have covered an opioid antagonist already, and that would be naloxone, brand name of Narcan there. Naltrexone is used in kind of a significantly different way than naloxone. So just kind of summing it up here briefly here, naltrexone blocks opioids' effects basically by binding to those mu receptors at a fairly high affinity. They do bind them pretty significantly, so other opioids can't bind there. With that said, I will say patients, there is reports of this as well, when you start blocking a receptor, what can happen is the body basically responds to that, and it's not feeling enough endogenous opioid activity potentially, or it feels like it may need to feel more. And so the body, because those receptors are blocked, starts upregulating receptors. So basically, creating more and having them more readily available to receive kind of that binding and the stimulation. So anyway, patients, because of this potential upregulation over time, they may be at more risk for opioid overdose, particularly in the setting if the patient, abruptly stops taking and then they initiate opioids and things. So patients may be at more risk for opioid overdose, and that's thought to be due to that upregulation of opioid receptors. Because naloxone being used on a chronic basis for opioid use disorder or alcohol use disorder is going to block those receptors and cause that potential upregulation. So definitely a challenging aspect to using this medication in these settings. So those are the two primary uses for naltrexone by itself. It's important for alcohol use disorder treatment to recognize that if patients are taking opioids, we probably want to avoid naltrexone because that's going to directly block the effects of the opioids. Same thing with acute pain management and scheduled surgeries, for example, where we may use opioids. In the event that we don't have other options that are good for the patient for pain management and we still have to use opioids, we've got to recognize that this patient's on naltrexone and develop a plan to basically address that. So in alcohol use disorder, avoid taking opioids. Another situation to avoid is hepatic impairment. Naltrexone is associated with causing some hepatic issues, and I'll touch on that in the adverse effects. In alcohol use disorder, it may be started even if drinking. So some of the original agents we had for alcohol use disorder, like disulfiram, for example, basically causes nasty adverse effects if you take or use alcohol with that medication. Naltrexone actually can be initiated or started even while the patient is still drinking. So that's kind of an interesting one there. In opioid use disorder, if we're using naltrexone, pay attention. It's not recommended to start naltrexone until the patient is opioid free for 7 to 14 days. And this can kind of depend upon, the half-life of the opioid that the patient's using, for example. So say they were taking methadone, which has a really long half-life. Well, anyway, if we give that naltrexone too soon, the situation we end up in is we're going to basically precipitate opioid withdrawal. And so that can be a challenge with the initiation of naltrexone in opioid use disorder. So again, do not start typically until that patient is opioid free for 7 to 14 days, in that range. Dosing, oral dosage form, we've got 25 to 100 milligrams is kind of the usual dosing range. 50 is probably the dose I've seen utilized most often. The IM formulation is every 4 weeks, so 380 milligrams. Obviously, that can be advantageous, potentially in a patient population that may not be very good at medication adherence, for example. I have seen that injection interval maybe once or twice, less than 4 weeks, but that's probably more of an off-label thing. Done by a specialist in patients that aren't quite responding the way that we'd like to and things. But there isn't a ton of data to really support that. But that is something that I have seen a couple of times. All right, let's chat about adverse drug reactions. So in general, some of the maybe more common things are stomach upset, nausea, vomiting, diarrhea. That can happen. I wouldn't call it crazy high percentage, but just be aware it's out there. It can happen. Syncope has been reported as well. Hepatotoxicity. This is definitely something that could come up on a board exam for sure. You've got to recognize that naltrexone is associated with hepatotoxicity. In our patients with alcohol use disorder, you really especially better recognize this, because patients typically who have had alcohol problems, or somewhat commonly, may have liver issues as well. And so that's one where you really got to pay attention to if we can use naltrexone or not. If they do have pre-existing liver issues or active liver dysfunction in alcohol use disorder, then we might be looking at something like a camprosate, for example, there. Opioid overdose risk, I kind of alluded to that already. Recognizing that we could have that upregulation for opioid receptors. With the injectable formulation of naltrexone, the IM injection, we can certainly have some injection site reactions, pain, bruising, even severe things have been reported, such as infection, hematoma, and things of that nature too, so pay attention to that. Of course, it may precipitate withdrawal. So keep in mind some of those opioid withdrawal symptoms, sweating and GI upset and things of that nature. Depression, increase in suicidal thoughts, these have been reported as well. I wouldn't call it crazy common in my experience, but definitely I think it's important to be aware there anyway of that. Okay, pharmacokinetics. Duration of action for the oral formulation is in the neighborhood of 24 to 48 hours. So that's typically going to cover us for the once daily dosing for the oral formulation. And then monitoring, of course, depending upon what we're treating, our monitoring parameters may vary a little bit. From a lab standpoint, LFTs are going to be the most important thing with regards to lab monitoring and adverse effects associated with naltrexone. All right, let's take a quick break from our sponsor, and we'll wrap up with drug interactions. If you're in the market for any pharmacist board certification study material, we've got a bunch of resources on BCM TMS, BCPS, ambulatory care, geriatrics, NAPLEX exam, all at meded101.com/store. We've had thousands of customers at this point, and definitely have helped a lot of them prepare and pass their exam. So simply by supporting meded101.com/store, you can help support this podcast. If you're another healthcare professional, we've got growing resources there as well. We've got stuff for nursing students, pharmacy technicians, med students, PAs, nurse practitioners, books on case studies, drug interactions, primary care, all sorts of different stuff. That entire list of books on Amazon, Audible books, you can find all those links. Go check it out. Support the sponsor, meded101.com/store. All right, wrapping up with drug interactions. Not a ton of drug interactions with naltrexone, so that is definitely a nice thing. The things that I look out for the most, opioid use. So reminder that if a patient is on opioids and you start naltrexone, it's likely going to induce opioid withdrawal. So we've definitely got to remember that, because the drug is going to prevent opioid agonists, such as morphine, oxycodone, and so on and so forth. Naltrexone is going to block those opioids from binding to their appropriate sites and having the analgesic action. So definitely recognize that opioid effects are likely going to be blunted with this medication. And really the only other major thing that I think of with drug interactions and naltrexone is the hepatotoxicity risk. So recognizing if you've got patient on amiodarone, methotrexate, isoniazid, maybe higher doses of acetaminophen, valproic acid. These are all examples of medications that can cause some hepatic impairment, and that may have kind of some additive effects on top of the hepatotoxic nature of naltrexone. So definitely something to pay attention to if a patient's at a little bit higher risk there. And then I did want to also reemphasize, if we're using it in patients with alcohol use disorder, they may be more prone to having some of those pre-existing liver issues already. All right. Well, I think that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor. Leave a rating, review on iTunes or wherever you're listening. Support the sponsor, meded101.com/store. And, of course, go get your free PDF at reallifepharmacology.com. Continue to share us with friends, colleagues, healthcare professionals, students that you work with. Help us grow the podcast. Help us educate as many healthcare professionals and future healthcare professionals as we can. We greatly appreciate that. If you have comments, suggestions, didn't like the way I presented something, thought I made an error on something, definitely don't hesitate to reach out. mededucation101@gmail.com. Or you can track me down, Eric Christensen, PharmD, BCPS, BCGP, on LinkedIn. I am certainly not immune to making mistakes. Hopefully I don't make many. But of course, I'm definitely human in that capacity for sure. So with that said, thank you so much for listening. Greatly appreciate it, and hope you have a great rest of your day.